Thank you, Dr. Jayant. Thank you for the privilege of being a part of this lovely course, which I have been a part of for the last few years, and it is a very popular course. The talk that I'm going to give you is about some of the changes that we've had in our practice of lacrimal diseases over the last few years, which have contributed to better results in these cases. So we will talk about changes in the congenital nasolacrimal duct obstruction, where we find that in failed cases, particularly inferior turbinate in fracture is a major contribution, because it creates that additional room for you to either be able to endoscopically see it, find the area where the probe is protruding, and to be able to take care of those complex cases. Balloon dacroplasty is another area, and endoscopy is certainly the one major change that has taken place in management in congenital NLDO. So we will talk about them in the context of the failed cases. Acquired obstructions, we'll talk about the punctal obstructions where there has been a change in thinking and in approach, so that probably the amount of surgery that we were doing earlier has reduced significantly. Canalicular obstructions, we will talk about the cistler trephination, and we'll talk about the newer approaches for making conjunctival DCR a much simpler procedure, and there again endoscopy plays a major role. In the acquired nasolacrimal duct obstruction, we'll talk about the endoscopic dacrocystorhinostomy. There is also a non-endoscopic transnasal DCR, which we do not have much experience of, and transcanalicular recanalization is another area. These two areas have become important, but we do not carry these out. So transcanalicular recanalization is again through an endoscopic approach which has been designed specifically for going through those canaliculi and recanalizing it under direct vision. So I'll talk about the procedures that we normally use in our practice. So talking of failed probing, the various approaches that you have is, if it has been done in somebody else's hand, then you can repeat that probing, usually with a gap of at least about 6 weeks. But if you've had a failed probing in your own hand where you are sure that things went well, then you probably need other approaches. Cases where the persistence of epiphora is present are many a times because of close approximation of the inferior turbinate to the nasolacrimal duct opening, and therefore the inferior turbinate in fracture alone suffices in many cases, even if you do not have access to endoscopes. Balloon catheter dilatation is a costlier approach which can be used in resistant cases, and we'll see what role it has. Silicone intubation is certainly an advantage in special situations, which we'll again talk about. And endoscopic assisted probing is the most important newer advance in cases where there has been a failed probing. And beyond 3 years, of course, if you have a failed probing on 1 or 2 occasions, then you need to create a dacrocystorhinostomy, and these are usually the cases which have a bony obstruction or the nasolacrimal duct bony canal which is not developed well enough. So inferior turbinate in fracture is generally carried out under general anesthesia, and after initial vasoconstriction of the nose by nasal packing, usually using a good concentration of adrenaline, as much as your anesthetist would allow, you can get a good hemostasis and then cause the inferior turbinate to be rotated in, so that the area where the nasolacrimal duct is opening can be free from any obstruction due to mucosal swelling. Many of these cases will have intermittent probing, so whenever they get a little congestion in the nose, they tend to develop watering and discharge again. So the use of a generally artery forceps or more often a periosteum elevator gives you the feel of the inferior turbinate, and you can fracture it in 3 different motions, doing the anterior part first, then the middle part, and then the posterior part, and you give a very clear give, and you can create that extra space which allows the success of many of the failed cases. But where you can combine it with an endoscopic observation of where the probe is appearing, it helps increase the success rates. Now, balloon catheter dilatation is a modality which has been available for quite some time now, and it is particularly useful in failed intubations, complex cases of nasolacrimal duct obstruction, which is defined as the abnormal openings, which are the where nasolacrimal duct is not opening into the inferior turbinate directly, but also it has been used as a primary procedure. Now, the advantage is that it allows greater dilatation because balloons are directed, they give a pressure radially on the duct once you have opened the obstruction, and therefore they do not produce tears, and it is a relatively less invasive procedure. However, results are not any better than intubation in cases of failed probing according to the large multicentric PEDIG study, and they are costlier. So this has balloon size of 2 millimeter for up to 30 months of age, and a larger balloon is used for older patients. And then you carry out 2 cycles of balloon inflation at 15 millimeter marking and at 10 millimeter marking when you have pushed it. And first cycle of 8 atmospheric pressure, second cycle of same pressure for 90 and 60 seconds respectively. This is to give that sustained period of dilatation, and this is how you create the pressure with an injection, and the balloon here inflates, and once the balloon inflates, it causes a dilatation of the entire canal. Now this is how you carry out the procedure, and for those much time, but since the results have not been shown to be much better than the intubation is carried out more often. Now let's look at the role of nasal endoscopy, which I think for congenital cases is the major advancement that has taken place. Especially useful again in the same situations, complex NLDO, failed probing, and there are those cases where there is a congenital dacrocystocele. Now these cases often have a nasal cyst associated, and sometimes they are bilateral. Now these are the cases where nasal endoscopy is important.